to the didactic motivational interviewing and its effectiveness. So, I mean, what is motivation? So it can be defined as a mental process, function, or instinct that produces and sustains an incentive or drive in either human or animal behavior. So it can have various components. That is the degree of discrepancy between the current behavior and future values, the confidence for change that the organism has, that is a self-efficacy, and also setting priorities, goals as to the change that needs to happen. So, I mean, the assumption in any kind of motivation that the human being is always in a state of ambivalence, whether to change or to actually remain status quo. So, I mean, we would make, so this, everyone would have seen this decisional matrix where what are the pros and cons of changing the behavior versus pros and cons of not changing the behavior. So it's like a seesaw. At some points of time, so one of the important things is that motivation is always dynamic. Like a seesaw, I mean, it can come, I mean, it could be the pro change that would be acting at one other point of time, but maybe because of some other reasons, it may be back to status quo. So it's like a seesaw, and what it means is that the motivation is a dynamic phenomenon that is there. So what is motivational interviewing? It is a tool for helping people to change. It was developed by Miller and Rolnick, and you can define it as an empathic, person-centered. So it's client-centered. It has its origins in humanistic psychology, counseling approach that prepares people for change by helping them, by resolving ambivalence, enhancing intrinsic motivation that is there, and building confidence to change. So, I mean, it is collaborative. So the most important thing about motivation, it is collaborative. It's not something which is directive where the therapist asks the patients to do. It is collaborative. It is goal-oriented. So always with regards to the motivation is to actually reach a particular, it's a goal-oriented, and it's a style of communication rather than a therapy. It's a style of communication that the therapist must develop. So it's a collaborative, goal-oriented style of communication, which pays particular attention to the language of change. So it's the change that is the primary unit factor, and we pay attention to the change talk that is there, which will be discussed in the later part. So there are various elements of motivational interviewing that is there. That is the spirit of the various principles that are there. What are known as ORs and the change talk. So, I mean, how do we actually go about the motivational interviewing? It is partnering with the patients, non-judgmentally accepting their stance. So, I mean, that is something that, so a lot of the times, especially in people with substance use, there would be, it's like this particular client whom we had discussed. So there was a lot of blame with regards to substance use as to the reasons for his substance use with the external environment that was there with his wife, with the different environmental factors. However, I mean, we should accept them initially, and we should be non-judgmental with regards to whatever has happened. Showing compassion. And the crux of it is actually evoking patient's own arguments for change. So it's not directive. The assumption is that the patient has the resources to actually bring about change, actually bring about the plan for change. And we are only acting as a facilitator in invoking that change. So there are the 4 processes of motivational interviewing. The first would be actually engaging. That would be the initial part, as in any kind of therapeutic processes where we would actually try and build a rapport with the patient. Focusing. So focusing is actually deciding upon a goal with the particular client. Again, taking the example of the previous case, though, I mean, in my last he had come for a follow-up last time. He had actually relapsed on cannabis on this thing, but I mean, his main focus was that he wanted a job, and so actually our discussion was regards to how we could go about it, and we actually agreed upon actually discussing about, I mean, what kind of different to actually talk about job and getting a job in the future session. So I mean, actually arriving on a goal after discussion with the patient would be focusing. Evoking. So evoking is actually what you would try and do is try to elicit and explore the patient's own reasons for change, so that the client himself is actually bringing about the reasons for the change, so that he is really more motivated. And planning, of course, coming up with a very solid plan to how to actually go about bringing that particular change. So these are the 4 processes. Engaging, that is actually building rapport. Focusing is actually in discussion with client, agreeing upon a mutual goal. Evoking is actually eliciting and exploring the reasons for change that the patient has, and actually planning for the change coming ahead. So there are the principles. So there are four. These come under the acronym DARES. So, I mean, the first part of this is developing discrepancy. So a lot of the time, as we told, clients are ambivalent to change. So how can we go ahead? So one of the things that we can do is actually giving a personalized feedback. So in a person who has substance use, I mean, the kind of impact the substance use had, giving a personal impact, personal feedback with regards to that. If someone has had a seizure, in withdrawal phase, giving that the medical, I mean, different kinds of personalized. The feedback should be always personalized, as well as actually trying to find out after the personalized feedback. So if you, how does the particular, let's, for example, the substance use compare to his future goals? So if he continues using the substance, how would it actually impact upon his future goals? So, I mean, future goals. So, I mean, this would actually help to bring about a discrepancy. It also helps using a decisional matrix. So this is an example of, like, quitting smoking versus continuous smoking. What are the benefits versus the harms which are there? And so once the person actually brings about a decisional matrix, you would actually discuss with regards to them actually the pros of quitting versus the cons of quitting, and actually help them to make relevant decisions and choices which are workable in the future. So, I mean, so these are two techniques, and by which we can actually develop discrepancy. The next part of it is avoid argumentation. So, I mean, that is self-explanatory. That, I mean, once you get argumentative with the patient, I mean, our rapport is lost, and actually, so that is the next would be to roll with resistance. So, I mean, resistance, I mean, comes in different forms, where the patient might be arguing with you during your session. It might be denial, that he would deny that there is a problem because of substance use. He may have had a road traffic accident because of alcohol use, but he would deny that there is no problem in substance use. It might be ignoring. So you would be giving about, discussing with him and giving various feedbacks with regards to that, ignoring those feedbacks that you're giving with regards to substance use, and interrupting you multiple times when a discussion is going on. So these are various forms in which resistance can actually come about. So one of the most important things to understand is do not oppose resistance. So resistance is not something that is abnormal. It is normal. So when you're looking at substance use, you are discussing with the client to bring about a change in that behavior. So this is a behavior that has been there for some period of time. So you are actually going to expect resistance. And basically, when you actually meet resistance, it is a signal. It's a signal for the therapist that, our interaction with the client is, our interaction with the client should change. I mean, there is something that we have to do differently with regards to actually coming, to actually get over the resistance. So you would actually roll with resistance. So one of the things that you could do is reflection. So reflection is that if I would be discussing with regards to smoking or any this thing, the person is discussing about the smoking and breathlessness. So you would actually make a statement. So I understand that you have had breathlessness with smoking. So one thing is that the client would understand that you are actually paying attention to his concerns, and actually it's a validation of the particular concern that the client has. So, I mean, that is one and essential step that is needed to be there. The next thing would be shifting focus. So, I mean, that would be the example from this client we had discussed before, where actually, with regards to the substance use, he was still continuing to be contemplation. So we actually agreed upon a goal, that is, we would actually talk with regards to his occupation. So, I mean, there are different goals that a client might have, and you should, the goal with which we discuss in motivational interviewing is mutually made. So you actually shift focus to a different goal. We may actually reframe. So for an example for reframing is when a lot of times adolescents with substance use come to us. So it's not just the substance use. So when we actually really explore, there would be a whole host of behavioral problems that would be there. So a lot of the times in adolescents who come to our clinic, and we actually find out along with the substance use that there are behavioral problems, we would actually talk about, try and find out whether there has been any attention deficit hyperactivity disorder, any kind of externalizing syndrome. So we would actually reframe the problem. Okay, we understand that your current issue is is a difficulty in actually focusing, not completing your work, getting angry easily. Not being able to study. So, you actually reframe the problem that, you are not, from the fact that, the parents would to telling that you are an addict, to that you have difficulties in actually concentrating, keeping attention in class, in actually keeping your anger under control. So, you are reframing that problem. So this is another technique that you can actually use to overcome resistance. And siding with negative. So, example for that would be, so a lot of the times the client would be in ambivalence. So if you take an example of someone who smokes, he would say that I am concerned with regards to my smoking because I have breathlessness. But however, without the smoking helps to relieve my stress. So, when you actually find out that what are the two sides of the coin, you would actually, when you, as a therapist, what you would do is, okay, I understand that smoking helps you to relieve your stress. So that's sort of the negative side of the coin that we as health professionals are concerned. So actually the client would have the option of actually talking about, but if I actually stop smoking, that would be breathless. So that's a positive kind of vibe that comes about. So these are different techniques that you can actually use to roll with resistance. And the other things are expressing empathy, which is and supporting self-efficacy. So self-efficacy is a lot of times, it's very important. So you can define self-efficacy as the degree to which a patient feels confident and capable of performing a behavior in a specific context. So again, with regards to the substance use, a lot of the times the client would be not confident. So a lot of the time, once they are admitted in our center, when they go out, they would be not confident that they will be able to actually abstain from alcohol. To actually enhance their self-efficacy, it is something that is very important. It has been shown in a lot of studies, especially with regards to the relapse prevention, that self-efficacy is one of the important relapse determinants is there. So supporting the self-efficacy is something that is very important in motivational interviewing. So what are the principles? So how do we actually interview a patient? So one of the things is open-ended questions. So open-ended questions are generally asked with what, tell me, how is it that this thing, generally why questions. So these are open questions, so that there shouldn't be a yes or no answer to our question. So the questions is how has your substance use affected you? So this is an open-ended question. It could be the person can give. So he has the option of giving physical problems that might have happened, psychological side effects that might have happened. So this is an example of open-ended questions. The second one is affirmation. So affirmation is actually believing in your client, actually giving a positive feedback to the client. So a lot of the times that when they come, you can tell that, I'm happy that you have come. I'm happy that though you had a single lapse, you were able to actually maintain your abstinence thereafter that. So actually they should be genuine. They should be about the achievements that the patient had. So because a lot of the times people with substance use have significant negative vibes from the environment. So affirmation that would actually also help improving their self-efficacy is something that is very important. The next is actually reflection. So when you have, there are different kinds of reflection that can be used. One would be simple reflection that we had discussed. So that would be, I understand that smoking has worsened your breathlessness. It may be double-sided, where you actually talk about both sides of the coin. I understand that the smoking has, you want to stop smoking because of the breathlessness. However, you're also concerned about the fact, without smoking, how are you going to cope with stress? So you talk about both. It may be amplified. In the what you do in that is that there may be a feeling that is there again inside the patient, in the sense that, again, with regards to the smoking, I understand if you're talking about a positive aspect. I understand that you're concerned about the breathlessness that you have had with smoking right now, and you're also concerned how it will actually play out in the future. So what would be the long-term consequences of that? Or a lot of the times, a lot of clients would have a lot of frustrations with regards to the family's pressure. So I understand that you're frustrated with how your family is putting pressure over you, without understanding the fact how difficult it is to stop smoking and the efforts that you're putting in. So, I mean, this would be the actual meaning behind the statement that the person makes. So this kind of reflection actually helps to validate the patient. It gives them a feedback that you are concerned with regards to their problems, you understand their problems. So this is something that is very important. And then finally, summarizing. So summarizing whenever you finish a session, or whenever a particular part of your discussion is ending, so at that point of time you summarize to actually ask the patient whether you have understood their difficulties correctly. And also, after reflection and summarizing, you should actually give the person some degree of time to sort of respond back whether you have actually understood their problems correctly, or if your understanding needs correction. And there is different levels of change talk. So the desire would be like, so it can be desire to actually stop using substances would be there. And the ability. So one example with desire, I would want to stop smoking. So these are the kind of desire state. Want, the word want in the statements would be one of the things for the desire. Ability is, I have been able to finish my MD, my DM. So I should be able to stop smoking. So in the ability statements, the patient would, based on the resources. So there is something that he has done in his life in the past. So based on those resources that he had used to actually succeed in that particular endeavor, he will be able to stop. Reason would be, if I do not smoking, I might be actually fired from my job. So a particular reason for this thing that is there. And actually the next is need. They've written ability. So that I need to stop smoking, otherwise my health will and it can be also the commitment to change that the person might make. So like, I have decided to quit smoking on Thursday or this particular day. And activating language. So I have decided to go to the doctor tomorrow and get admitted for my problem related to substance use. And taking some kind of steps, whatever. So these are the different kinds of words that you have to actually listen to in the conversation which is there with the patient. So always a feedback should be given, and the feedback should be personalized. So that is something that is very important. And a lot of the times this motivational, interviewing, it is actually understood in the, stages of change is different from motivational interviewing. But a lot of the times we describe that, the motivation to have been enhanced based on the stages of motivation that the patient is progressing from pre-contemplation to. So pre-contemplation, the patient is unaware of the problem. So contemplation, there would be ambivalence with regards to actually stopping the substance or actually continuing with the substance. Preparation, he has made steps. In action phase, there are continuing various steps that the patient makes to actually stop using the substance. Maintenance is the change that has been maintained. So a lot of the times, the motivation to stop substance is described in the terms of these stages of change, but however, they are slightly different. So, these are different steps that can be actually, used to different techniques that a client, a therapist can use to actually progress from one motivational stage to another. And finally, when you actually do that, you should make a change plan worksheet. So the changes I want to make are the most important reasons for the change, the steps I want to take, the way other people can help me, and what are the things that would interfere with the plan, and I will know. So, you can actually make a change plan worksheet so that the person actually knows how to go about making the change. So this is what you can do. And actually, Miller and Rolnick told about 10 things that motivational interviewing is not. So as I told that, though the trans-theoretical model of change, that the stages of change that Prochaska and De Clemente have given, they are different. lot of the times we use the stages of change to actually describe that the motivation is actually progressing from one stage to another, but they are actually different. It's not a way of tricking people into doing whatever you want them to do. And it's not a technique per se. As earlier described, it's a goal-oriented style of communication, and it's collaborative. And it's just not about the decisional balance or the decisional matrix that is there. It's not an assessment or a feedback. It's not a brief intervention such as in frames. So something like the brief intervention in frames that was discussed in the first week. I mean, they also employ principles of motivation interviewing, but it's like, it's not with regards to cognitive behavior therapy. There are no specific cognitions that are tapped, reframing those cognitive errors that are there. That is not done. And it also incorporates principles of humanistic psychology, but the primary this thing is that actually the therapist actually watches out for the language of change and actually tries to reinforce any kind of motivation for change. It's not something that is easy to learn, and it's not practice as usual. I mean, this is a technique that needs learned, and it's not a panacea. I mean, it's not a solution for everything. Motivational interviewing not work in every client that is there. Which brings to some of the effectiveness studies that are there. So I've just so Project Max, that something that every one of you must have this thing. I mean, this was a study that was done in the USA in 1990 to 97, where the efficacy of motivational enhancement therapy was compared with cognitive behavioral therapy as well as 12-step facilitation. It's a large-scale multi-site study, and so basically in this particular study, the client factors were tried to match with a particular kind of therapy. But however, no study was found to be effective over the other study. The only thing that was there is that in this, as per the study definitions, only 4 sessions of motivational enhancement therapy were there, whereas for CBT and 12-step facilitation, actually 12 sessions. So actually only 1/3 of the sessions were held for motor. So that's something that the proponents of MET actually point out. There were much lesser sessions in motivational enhancement therapy. And actually equal efficacy was actually found towards the end of the study. Now I'll be describing some systematic reviews and meta-analysis that was there. So this is one that is motivational interviewing for alcohol misuse in young adults. So this was a meta-analysis that was done. There was 66 RCTs with more than 17,000 patients. So I mean, there has been some reduction with regards to the quantity, frequency, and of alcohol use, and marginal effect with relation. So there are only marginal effects that are there. So they actually, in this particular meta-analysis, they actually conclude there is no substantive, meaningful benefit of motivational interviewing. So I mean, this is something that keeps recurring. So this is a motivational interviewing for substance abuse, largely alcohol abuse. So again, here they actually compared motivational interviewing to no intervention, with to just assessment and feedback, with to other interventions like CBT, which is there. And so what was found that motivational interviewing was definitely better than no intervention or just assessment and feedback. But however, and the effects were mostly for, and the effects actually waned over time. So that is what is seen. But it is not superior over any other intervention which is there. That was the conclusion of this meta-analysis. And with regards to smoking, tobacco users, so in that, motivational interviewing appears to help more people to quit smoking rather than just briefer advice, and shorter sessions actually helped. There was actually a comment of publication bias that was there. And this is actually motivational interviewing, as you know, it's not just used in substance use. I mean, it's used in a lot of this is actually a meta-analysis with actually lifestyle intervention. So there was apparently a significant effect of motivational interviewing with estimates of body mass index, total blood cholesterol, systolic blood pressure, blood alcohol concentration. So I mean, it actually, as per this meta-analysis, there was definitely some effectiveness for motivational interviewing. Some of the actual critiques is that, as again discussed earlier, motivational interviewing is a style of communication. So it is driven entirely by the patients, the motivations of the patients. So you are not actually trying to sort of change. So the discussion with regards to is the motivation, the goal of the particular patient. So it's the patient who, the client who actually drives the therapy. Whether this kind of actual analysis, qualitative analysis, really, whether it really does justice to motivational interviewing is what some people question. So these are some of the meta-analysis that has been done in this particular field that is there.